Okay, folks, we'll resume consideration of Chapter 5 with the Saskatchewan Health Authority, Chapter 5 of the Auditor's Report, and we'll continue back to the questions. Looking over here to see if anyone's on deck. I know Ms. Young was on deck with a question when we had our recess. Ms. Young.
Thank you. Thank you very much, Mr. Chair. Returning to recommendation 6 from the provincial auditor pertaining to improved communication of supplier award decisions needed. In Chapter 5 of the Auditor's Report, it's noted that between April 1st, 2020 and February 2022, the authority received 2 complaints, and 1 complaint was resolved, and the other complaint was still in the process of being resolved. I'm wondering if you can update the committee on the status of that second complaint, as well as detailing kind of what that resolution process looks like, whether there are any current complaints, and what, if any, costs are associated with those.
On that specific outstanding complaint at that time, I'll have to follow up with my team for more details on that. So I'll follow up and I'll bring it back, an update on that as well if there's any other outstanding complaints at this time.
Thank you very much. Moving on to the partially implemented recommendation number 8, in regards to a formal process to assess and track suppliers. It notes that the process is partially implemented, and it also notes that the timeline for implementation is TBD. Are you able to share with the committee some rationale to a little bit more information on what that process looks like and why the timeline is TBD?
So with this item, it'd be partially implemented. So we have partnered with 3S Health on the contracts that they manage for us to evaluate supplier performance. And that's something our procurement team partners with 3S Health on. And we evaluate the vendors from everything from quality, performance, a variety of metrics to assess what their performance is. Then we grade them based on a criteria of red, yellow, or green based on what the standards that we have. And if they're red or yellow, we'll come up with an action plan to work with that vendor on and get that put into place. And that process with 3S Health covers about 50%, close to that, of the goods and services that we purchase. Wouldn't quite be that, but it'd be close to that. And then for the remaining 50% that SHA manages the contracts of, the team is just currently, as we speak, developing and formalizing what that criteria would be to evaluate those vendors, leveraging the process that we have in place for 3S Health. And our plan is to have a pilot rolled out on that in the next fiscal year.
Thank you. And perhaps just one last question on this chapter to the provincial auditor. Recognizing there's a number of new recommendations, do the actions described by the status update as well as the good folks here today, you feel they represent like appropriate implementation of the actions recommended by the provincial auditor?
So in terms of us evaluating, I guess, the actual implementation of these recommendations, that'll be coming forward, I believe it's fall or winter of sort of the 2024, probably publishing out in 25 V1. But I would say that based on the recommendations we made, we envisioned a lot of them being relatively easy to implement. And so in terms of the actions that the SHA has described they have undertaken, yeah, I do anticipate the next time we go, I hopefully look forward to seeing all these recommendations implemented.
Thank you very much, Mr. Chair. No further questions on this chapter.
Just one before we open it up to see if there's any others. Just from page 78 of the report, the auditor identifies a tender of worth $726,000, where she, I think, identifies that the proper evaluation support didn't accompany it. Just what was that tender for, and who was it with?
I'll follow up with the team on that one as well and get more details on that. Thanks.
Right on, thank you. And that'll be within a month back through the clerk to supply that information. Is that all right?
No problem.
Thank you very much. Any further questions with respect to this chapter? I'd welcome a motion to concur and note compliance with respect to recommendations 1, 2, 3, 4, 5, 6, and 7, moved by Mr. Harrison. All agreed? That's agreed. That's carried. I would welcome a motion to concur and note progress with respect to recommendation 8, moved by Mr. Gowdy. All agreed? That's carried. Okay, we'll move right along here, and I'll turn it back over to the provincial auditor. She's going to be focusing on Chapter 12.
Thank you, Mr. Chair. The Saskatchewan Health Authority's Human Resource Department is responsible for recruiting the authority's 35,000-plus workforce, not including physicians, and for executing retention strategies. It routinely hires, organizes, staff orientations, provides training opportunities, and administers benefit plans for staff. At March 2022, the authority identified 31 hard-to-recruit positions, with 8 positions deemed hard to recruit because the vacancy is located in either rural or northern Saskatchewan. Chapter 12 of our 2022 report, Volume 2, reports the results of our audit of the authority's processes for the 12-month period ended March 31st, 2022, to fill hard-to-recruit healthcare positions. We concluded the authority had effective processes other than in the areas reflected in our 7 recommendations. Hard-to-recruit healthcare positions include those jobs responsible for directly delivering healthcare services where the authority experienced difficulty in recruiting and retaining staff with the competencies required for the role. Our audit did not include physicians or positions responsible for administration at the authority. On page 142, we recommend the Saskatchewan Health Authority determine in which facility locations across the province it expects to have the most significant shortages of hard-to-recruit positions. In June 2022, the authority issued its first comprehensive workforce plan covering the 2022 to 2026 period. Our review of the authority's plan found it contained the major elements required of a workforce plan: supply, demand, gaps, and plan solutions. The plan includes a workforce supply and demand analysis for hard-to-recruit positions, with the authority expecting about 765 staff in hard-to-recruit positions to terminate their positions within the organization each year, along with hiring close to 1,100 new staff each year. However, the plan still shows a shortfall in certain hard-to-recruit positions due to staff needed for new healthcare initiatives and current long-term staff vacancies. The authority expected a shortfall in staff resources for hard-to-recruit positions of almost 2,200 positions over the next 5 years, with its largest staffing gaps in positions for registered nurses or registered psychiatric nurses, continuing care assistants, and medical laboratory technicians. These positions can have a significant impact on the ability to deliver healthcare services in hospitals and long-term care homes. Our review of the authority's plan found it does not identify staffing gaps by healthcare facility location, which could help drive the recruitment and retention strategies required. Our analysis of data the authority used to support its gap analysis found it estimates new initiatives requiring over 700 additional staff in Prince Albert, Meadow Lake, and La Ronge over the next 5 years alone. This represents a significant staffing challenge for the authority, as it can be difficult to recruit staff to rural and remote areas, particularly in the north, and will require targeted plans. An analysis of expected staffing gaps by facility location across the province would assist the authority in determining where it needs staff most and help it prioritize and tailor its recruitment processes accordingly. Doing so should also help the authority to minimize service disruptions to the public. On page 147, we recommend the Saskatchewan Health Authority implement targeted plans to address recruitment and retention for specific hard-to-recruit positions where it expects to have significant gaps. The authority has generalized staff sourcing strategies for all healthcare positions in its workforce plan. Some of these strategies address hiring gaps as well as retention for hard-to-recruit positions. Examples of strategies include conducting career fairs at Saskatchewan's post-secondary institutions, advertising and social media recruitment campaigns, and purchasing training seats. We found the authority developed recruitment plans for some of its hard-to-recruit positions. These plans listed the actions the authority expects to carry out in the next year. We assessed the authority's recruitment plans for a sample of hard-to-recruit positions and found the plans lacked consideration of certain key areas, such as varied sources of qualified staff and consideration of root causes of hard-to-recruit positions. A lack of documented root cause analysis is a concern. If the authority does not know why it cannot recruit and retain staff, it can be difficult to build plans to address the underlying issues. For example, if the authority expects to have a shortage of continuing care assistants in La Ronge over the next 5 years, targeted strategies can help the authority focus its efforts towards addressing identified root causes specific to rural and remote recruitment. Such strategies could include the establishment of professional networks to support and mentor staff, or working with the local community to provide social supports, such as assistance finding housing, daycare, or spousal employment. The authority posts service disruptions at various healthcare facilities across the province on its website. Our analysis of the website as at July 2022 found a couple of service disruptions in healthcare facilities specifically due to healthcare staffing shortages in Kamsack and Biggar. Further expansion and variation of its strategies to fill hard-to-recruit positions will be necessary for the authority to limit further service disruptions to the public. Having an understanding of where in the province it expects to experience significant resource gaps may help the authority implement appropriate targeted plans. On page 148, we recommend the Saskatchewan Health Authority analyze whether clinical placements for students are a successful recruitment strategy for hard-to-recruit positions. Annually, the authority creates clinical placement opportunities across the province for about 4,500 healthcare students enrolled at Saskatchewan post-secondary institutions, with some of these placements for hard-to-recruit positions. The authority provides supervision and training for the majority of clinical placement students. However, we found the authority does not have a system to monitor student placement and performance or to track the number of employees it attracts as a result of these initiatives. In addition, while post-secondary institutions may conduct student experience surveys, the authority does not receive this information in a centralized way or conduct its own surveys to gain insight into student perspectives of the program or their views of the authority as a potential employer. Clinical placements are an important recruitment strategy that the authority is uniquely positioned to use. The authority needs to assess whether this strategy effectively helps to address its gaps in hard-to-recruit positions. Measuring the success of the strategy will enable the authority to consider the root causes of any failures and make necessary adjustments. On page 151, we recommend the Saskatchewan Health Authority periodically determine whether post-secondary training seats purchased out of province are successful at addressing vacancies for hard-to-recruit positions. The Government of Saskatchewan, through the Ministry of Advanced Education, signs interprovincial agreements to purchase training seats related to healthcare education at Canadian post-secondary institutions outside of Saskatchewan. This type of training is required for several hard-to-recruit positions, such as respiratory therapists. The government purchases the training seats to allow students who are Saskatchewan residents that meet the post-secondary educational requirements to access specialized healthcare training outside of the province. For the 2019 to 2022 period, the Ministry of Advanced Education spent an average of just over $2 million annually on securing these training seats available to Saskatchewan students who qualify for entrance into the respective post-secondary institutions. We found neither the Ministry of Advanced Education nor the authority have a system to readily monitor student placement and performance, or to track the number of students who return to the province to work upon completion of their studies. A lack of monitoring whether students using government-purchased seats return to work at the authority increases the risk that public money is not well spent. If purchased seats do not effectively address staffing variances, the authority should consider adjusting its approach. On page 154, we recommend the Saskatchewan Health Authority implement a First Nations and Métis recruitment and retention plan to help fill hard-to-recruit positions. The authority's 2022-23 public performance plan included a goal of developing a First Nations and Métis recruitment and retention strategy by March 2023. The authority asks staff to voluntarily self-declare whether they are First Nations or Métis, As a benchmark comparison, we compared the authority's January 2022 staff voluntary self-declaration results to the 2019 target set by the Saskatchewan Human Rights Commission and found the authority was only meeting the target in Northeast Saskatchewan. Although a First Nations and Métis recruitment and retention plan has not yet been developed, we found evidence of the authority's commitment to creating a more diverse workforce. For example, the authority had a targeted recruitment campaign for the rebuild of Prince Albert's Victoria Hospital. It also entered into a partnership with the Gabriel Dumont Institute in 2022 to provide additional access for First Nations and Métis learners to post-secondary seats. The authority committed to recruiting up to 450 qualified Métis students from the Institute from 2023 to 2028. While the authority has taken steps to create a more diverse workforce, lack of a First Nations and Métis recruitment and retention plan, including a diversity target, increases the risk of the authority missing other potential opportunities to create a diverse workforce and to fill hard-to-recruit positions. On page 154, we recommend the Saskatchewan Health Authority centralize its analysis of staff exit surveys to inform retention strategies for hard-to-recruit positions. Employee exit surveys help organizations assess the overall experience of staff during their employment and identify opportunities to improve retention and engagement. We found the authority does not have a centralized process to conduct exit surveys with staff prior to their departure from the organization. It used a patchwork of different surveys in place prior to the creation of the amalgamated authority in December 2017. As a result, the authority does not have a source of consistent data to allow it to analyze aggregate results from its exit surveys. Lack of analysis of staff exit surveys limits the authority's ability to assess the effectiveness of and adjust its recruitment and retention efforts for hard-to-recruit positions. In the final recommendation on page 158, we recommend the Saskatchewan Health Authority establish further measures to evaluate the success of its recruitment and retention activities for hard-to-recruit positions. The authority develops a public performance plan annually. Its 2022-23 performance plan included one target specifically related to the recruitment and retention of hard-to-recruit positions. By March 2023, the authority expected to have no more than 5% of permanent full and part-time hard-to-recruit priority classification positions vacant for more than 90 days. At March 2022, the authority had 11 hard-to-recruit positions over the 5% target of permanent full and part-time hard-to-recruit priority classification positions vacant for more than 90 days, with some positions vacant for more than a year. Positions with the most significant chronic vacancies included respiratory therapists, speech-language pathologists, and combined lab and X-ray technicians. We suggested other useful information the authority could use to assess whether recruitment and retention strategies for hard-to-recruit positions are working, such as measuring employee retention rates, the average tenure of employees who leave the authority, or the time to fill a position. Without sufficient quality measures to determine which recruitment and retention activities are working, it may be difficult for the authority to effectively address vacancies in hard-to-recruit positions. Improved data analysis should help the authority inform needed updates to and priorities for its recruitment and retention plans for hard-to-recruit positions. I'll now pause for the committee's consideration.
Well, thanks so much for the focus of this chapter, the important recommendations. This is the first time that we've dealt with these. These are new recommendations for the public accounts. I'll turn it over to Deputy Minister Smith for remarks, and then we'll open it up for questions.
Thank you, Mr. Chair. Surrounding the recommendation to determine the most significant shortages of hard-to-recruit positions, the SHA continues to use a vacancy dashboard to identify vacancies at a point in time and a 5-year projected forecast to determine any potential hotspots across the province. The SHA also monitors rural and remote communities experiencing disruption to determine where the SHA is seeing advances and where additional targeted work is required. Rural and remote incentives are available and utilized as recruitment tools to fill vacancies in these communities. The SHA and Ministry of Health are collaborating on a refreshed 5-year forecast that includes capital and service delivery expansions and takes into consideration the new supply based on increases to healthcare training seats announced in the winter of 2023. The new forecast will be adapted and used for ongoing workforce planning efforts across the Saskatchewan Health Authority. Further work is underway to build in functionality to support the ability to forecast at a more community service level. To implement the recommendation to have targeted plans to address recruitment and retention, the SHA has implemented project plans for all hard-to-recruit classifications. Additionally, the Saskatchewan Health Authority has aligned its 22 through to 2026 Health Human Resources Operational Plan with the Government of Saskatchewan's Health Human Resources Action Plan, which includes specific strategies and actions to address gaps in hard-to-recruit positions. Some of these strategies include aggressive domestic and international recruitment, enhanced and modernized social media advertising, partnerships with our post-secondary educational institutions and community organizations, First Nations and Métis recruitment retention strategy, new and enhanced full-time equivalents in rural and remote communities to support stabilization, enhanced recruitment incentives, and retaining and growing our people by promoting employee well-being, continuous learning, and succession opportunities. In regard to clinical placements being a successful recruitment strategy, the Saskatchewan Health Authority is developing a comprehensive plan that focuses on understanding the impacts of clinical placements through evaluation, trend monitoring, and detailed reporting to ensure effective management and optimization of the placement experiences. Regarding the fourth recommendation, the Saskatchewan Health Authority is collaborating with the Ministry of Advanced Education to determine options for evaluating, tracking, and reporting success measures for recruiting to the Saskatchewan Health Authority from purchased out-of-province training seats. Regarding the recommendation to implement a First Nations and Métis plan for hard-to-recruit positions, the SHA has developed a recruitment intention plan and is actively working on implementing this plan in alignment with its own operational plan around health human resources. Extensive engagement took place with Indigenous organizations, post-secondary institutions, some internal stakeholders within the authority to inform the plan and to develop the recruitment and retention strategies that are contained within it. Additionally, the Saskatchewan Health Authority is committed to building a representative, diverse, inclusive, and culturally responsive workforce. Statements are added to all Saskatchewan Health Authority job postings that emphasize the collaborative efforts to improve the health and well-being of our population, our commitment to diversity and inclusion, and our dedication to implementing the Truth and Reconciliation's calls to action. To implement the recommendations surrounding a centralized analysis of staff exit surveys, the Saskatchewan Health Authority has implemented a new exit survey tool and process to create consistent and centralized data to analyze for potential retention strategies related to hard-to-recruit positions. The Health Authority's ability to analyze the exit survey data will be based on the response rate of individuals leaving the organization, as it is a voluntary process. To establish measures for evaluating recruitment and retention activity success, the SHA is monitoring and reporting monthly all chronic, permanent, full, and part-time hard-to-recruit vacancies with the trend over time, including any increases to FTEs. This reporting is done by classification and location and further identifies where gains are being made and where additional efforts are still required. The Saskatchewan Health Authority is continuing its work to establish evaluation processes and metrics for hard-to-recruit strategies, including progress towards filling chronic vacancies. As part of evaluation efforts, the SHA has implemented quick tap surveys to assess recruitment and job fair event attendance and monitor the creation of healthcare in Saskatchewan profiles. The data collected supports informed decisions on ongoing recruitment efforts. And in partnership with the Saskatchewan Healthcare Recruitment Agency, further work will be done to identify additional outcome metrics related to new and expanded recruitment activities. Detailed tracking and reporting have been implemented for specific classifications and initiatives. Examples include tracking metrics such as new graduation nurse hires, international educated nurse recruitment, and filling of vacancies related to new or enhanced rural and remote positions. By closely monitoring these metrics, we gain valuable insights that inform our strategies and enable us to make data-driven decisions to enhance our recruitment outcomes for the province. Thank you.
Thanks for the comments and the update that was there on the status update as well. We'll open up to committee members here for questions. Chapter 12. Ms. Young?
Thank you. Thank you very much, Mr. Chair. And thank you for all the work undertaken on this very important file. I see with recommendation number 1 being partially implemented with the SHA and the ministry collaborating on a 5- and 10-year forecast. Are you able to speak to facility locations identified that the SHA expects to have significant shortages of hard to recruit positions? And I suppose if you don't have that information immediately at hand, also happy to receive it at a later date.
Good afternoon. My name is Mike Northcott. I'm the Chief Human Resources Officer with the Saskatchewan Health Authority. So to answer your question, we have identified that the forecast does not include the facility location detail at this point in time. So that's work that we need to do with the ministry. And so that is work we will do. But right now it's in aggregate situation by profession.
Great, thank you. So just to make sure I understand, you'd be able to identify, well, we have a staff gap of cooks, for example, but we don't know if they're in Biggar or Kelvington or Regina or specifically.
That's correct,
okay.
in the actual forecast document. Now, we do more detailed facility analysis that would dive into that, but the deliverable here is looking at the overall forecast and building that facility location level into that.
Perfect. And so hearing that's forward-looking in terms of the current state of data that you do have that currently by location. You are able to identify which positions are vacant in which locations around the province.
Okay, so as I said, we do have work to do around staffing levels at those individual sites. However, on our health career website, you are able to, every posting obviously has a location, and you are able to sort. So that is a source of information there. But our forecast is by occupation at this point in time, and so we have some more work to do to tie it to that facility location. I would also highlight, though, that the capital project plans have staffing plans associated with them and identify we need X amount of RNs and we need X amount of LPNs, et cetera.
Thank you. So just to make sure I'm clear, currently the SHA is not able to identify which facility locations are currently experiencing shortages of hard to recruit positions, except for going through the website and sorting by like positions available in, I don't know, Kindersley or Redverse. That would be the mechanism to identify that for the health authority.
Okay, so it is a combination of provincial information around vacancies, but then also local level. So envision a manager or a director in a local geographic area. They're knowing their facility, they're knowing their staffing, they're working with their local HR departments. The piece that we need to build is that bridge that connects the overall with the local.
Thank you. So in reading this chapter, part of what the Office of the Provincial Auditor speaks to is our concerns that when the Saskatchewan Health Authority does not have the staff available to deliver needed healthcare services, disruptions can occur. Workforce shortages lead to service disruptions. So just to be clear on my understanding, if workforce shortages are a concern for service disruptions, I'm hearing that the Saskatchewan Health Authority is not able to provide information in terms of which facility locations are currently experiencing staffing shortages, leading to healthcare service disruptions. Is that accurate?
The answer to that is yes, we do know which facilities are on disruptions, and we work to fill those vacancies. Those are obviously really important to keep those facilities open.
Thank you. Is there a list of those facilities experiencing workforce shortages causing service disruptions that's available for the committee?
So we do monitor disruptions on a regular basis, and it does change on a regular basis as well. So for instance, if we have a sick call, we may not have enough staff, so that may cause a disruption. So it's an evolving issue that we monitor closely.
Thank you for that answer. The question was about healthcare disruptions due to staff shortages, specifically for hard to recruit positions, not somebody calling in sick for an afternoon.
Okay, so as I said, there's many reasons for disruptions. Lack of hard to recruit staff or vacancies in that is one of those reasons. And that's why we've with support of government, obviously, being able to offer the $50,000 recruitment incentives to classifications that have been identified. To help address that, as well as 250 new and enhanced full-time positions.
Thank you. Those are great and welcome government commitments. So maybe just I'll ask this question just one last time. Just so the SHA is unable to provide on a facility basis information as to which facilities in the province of Saskatchewan are experiencing service disruptions due to workforce challenges or vacancy rates related to hard to recruit positions.
So the answer to that is yes, it can be provided and is provided, but it changes regularly, as you can imagine, with all the factors considered.
Thank you. I appreciate that undertaking. Looking at page 157, figure 12, and having heard the preliminary comments in regards to the chronic vacancy rates greater than 5%, is this figure available for the past year as well? And are you able to offer any comments on whether the numbers are trending in what we would consider a positive direction?
So yes, we do track those numbers regularly. In order to do an apples-to-apples comparison, we would need to run the numbers at the end of March to compare. But just to give you a flavor, when we look at our hard to recruit, our permanent part-time and full-time chronic vacancy rate has decreased from last January to this January by 1%.
That's great, and I also see in the report that there's I'm not sure if it's an annual, it notes a June report that goes to senior management on the overall vacancy rates. And I don't think there's a particular interest in January being the specific point in time. Any point in time is fine.
Okay. The June version was the HHR operational plan, is I think what you're referring to there.
Yeah, I'm not sure, just at the bottom of page 157, it
Yeah.
notes, yeah.
That's what that is, yeah.
It's by no means an expert on the inner reporting that happens on all of this stuff. Just working with what we've got. So I appreciate that. Thank you. You mentioned the rural and remote recruitment incentive. Maybe I'll just kind of shoehorn a couple questions in here in recognition of everybody's time. I'm interested if the SHA has seen an improvement since the announcement of this incentive in hiring those positions. And I'm interested in how many full-time employees of each profession have accessed the rural and remote recruitment incentive, and if you have information as to where those people are, how many FTEs and what positions. And again, if that information isn't something you have at your fingertips, happy to receive it at a later date.
So as of February 8th, 253 people have received this, and we can provide you a breakdown by location and classification.
Thank you. Thank you very much. I appreciate it. I'm also really glad to see the SHA is conducting exit interview surveys to inform retention strategies. Wish we had more time. I'd like to ask you like 30 different questions on retention specifically. I'm wondering if you are able to share some information and specific examples with the committee about the reporting and some of the data and trends that you're seeing from these interviews that you've collected so far.
So the exit survey goes to staff who exit once a month, and we started this in the fall, so we've had one cycle of this. So I can't give you trends based on one cycle. Yeah, and then we'll be doing quarterly analysis.
Perfect. Hearing, of course, you can't give a trend with one cycle. Is there any comment you can offer on what I suppose would be the start of your baseline data then?
Not at this time, as we're just working through it.
Thank you. Can you clarify what the distinctions are? I don't know if it would be from a governance perspective, but looking at the healthcare recruitment agency and how SHA and your team, priorities of the healthcare recruitment agency, how all of these fit together from a strategic and governance perspective, and essentially like who's steering the ship and how are you all working together to address the concerns identified in this chapter?
Thanks for the question. I will maybe just start with this piece just to try to help kind of connect the dots to your point around like how does this work? So we've obviously got each of the organizations that are a part of Health Human Resources as a whole. And with the creation of the Healthcare Recruitment Agency, again, the intent there was to really bring some focus to the priority and the importance of health human resources in the province, and to also be able to provide that ability for the recruitment agency to really focus on the recruitment needs of the province as a whole. And so how it's working so how I would describe how it's working in practice is just at the very highest level. I would say that you've got the ministry that works obviously very closely with the agency, with the health authority, with the cancer agency. When I think about the healthcare employers of the province, our two primaries would be the cancer agency and the health authority. And so it's this combination of sort of that there would be information sharing, there would be sort of working through what are the priorities as a whole. What the agency's been doing is it's been going and meeting with a whole range of stakeholders, including the employers, and a part of those conversations are to enable the SHA, for example, to really reinforce with the recruitment agency, what are the priority positions that are needed, and how quickly do they need them, and really try to sort of lay out what those priority areas are. And similarly for cancer agency. And then it will be the recruitment agency's responsibility to be able to go and try to identify sort of individuals that might be ready for employment for those particular positions. So then they could be going to recruitment fairs. They do a lot of work with the academic institutions to identify students that would be potential employees of those agencies. And so I guess how I would sort of sum it up is it's very collaborative. We need all of the partners need to be working very closely together to identify what the priorities are and the actions that we're going to take. The other piece that I would add is that we're also really taking a broad approach in the sense of you've got the Ministry of Health involved, connecting really closely with our partner ministries as well, like advanced education, immigration and career training, trade and economic development. And again, the reason for that is, again, we all need, because of the priority of this area, we all need to be working really, really closely together. So in terms of just the agency itself, again, it's been underway for the last number of months, and sort of the expectation there is that they're working really closely with everyone to really understand what the needs are, and then be able to go and recruit for those positions.
Thank you very much. I don't want to belabor this point too much, but is there a formal governance structure in terms of how those pieces all fit together?
So we do have a Health Human Resources Partnership table, and Aaron Brady, who's the CEO of the recruitment agency, sits at that table. So that includes members of the Ministry of Health, myself from the SHA, Cancer Agency, reps, and reps from other ministries as well, and organizations, including Cancer Agency.
Thank you. Thank you very much. I think recognizing the time, I will leave it here for now. When do we expect this back to committee?
Maybe I'll ask the auditor just to comment on the process now of the follow on this front, and then her report back to us.
A fair amount of these recommendations, I would say, we know are complex and challenging. So I definitely think that this will take potentially, the 5 years for implementation, but we do have plans to go back in 2025 to evaluate the status of the recommendations at the time, with our report coming out in basically our volume 2, 2025. So then obviously usually the Public Accounts Committee wouldn't see that chapter for about a year's time. So you're probably 2026, just so you are aware. So a couple years from now.
Any further questions, folks, with respect to this this chapter? Certainly very important work that's being undertaken on this front and being committed to, and I want to thank those that are involved in that work. With respect to the recommendations before us, I'd welcome a motion that we concur and note compliance with respect to 2 and 6, moved by Ms. Lambert. All agreed? That's carried. I would welcome a motion that we conclude and note progress with respect to recommendations 1, 3, 4, 5, and 7. Moved by Mr. Gowdy. All agreed? That's carried as well. We'll keep moving along here and turn our attention to Chapter 18, and I'll turn it back over to the Provincial Auditor and her office.
Thank you, Mr. Chair. The Saskatchewan Health Authority is responsible for delivering accessible and responsive ground ambulance services to the people of Saskatchewan. Accessible and responsive ambulance services can be challenging because of the geographic spread and remoteness of some communities in rural Saskatchewan, including Swift Current and surrounding area. Chapter 18 of our 2022 report, Volume 1, reports the results of our second follow-up of management's actions on the 6 recommendations we made in our 2016 audit about the authority's processes to deliver accessible and responsive ambulance services in Southwest Saskatchewan. By December 2021, we found the authority implemented 5 recommendations. The authority improved its monitoring of ambulance operators' compliance with expected ambulance response times and began receiving regular reporting for all ambulance services. It also worked with the Ministry of Health to develop a performance-based contract template for the provision of ambulance services and signed 28 new contracts for 32 privately owned ground ambulance services in Saskatchewan, including 4 out of 5 in Swift Current and surrounding area. Finally, the authority and the ministry conducted a sufficient analysis of supply and demand for ground ambulance services across the province, considering input from ambulance operators. We found the authority had not yet implemented the last remaining recommendation on page 199, where we recommended the Saskatchewan Health Authority report to senior management, the board, and the public actual results against key measures to assess the success of its ground ambulance services at least annually. We found once the authority signs performance-based contracts with all 53 privately owned ambulance service providers in the province and implements a new dispatch IT system, it will have better information about service quality. Collecting better performance information will allow the authority to regularly assess the success of its ground ambulance services and publicly report on ambulance response times in Swift Current and surrounding area. I'll now pause for the committee's consideration.
Okay, thank you very much for the focus, the very important focus on this front around ground ambulance. I'll turn it over to the Deputy Minister for brief remarks, and then we'll get into the questioning.
Thank you, Mr. Chair. The provincial auditor noted that the recommendation surrounding assessing for optimal distribution of ambulance services has been implemented in its 2022 report, Volume 1. The Saskatchewan Health Authority and the Ministry of Health conduct analysis of the supply and demand for ground ambulance services across the province, considering input from ambulance operators. In addition, the Ministry of Health reviews ground ambulance services annually. The provincial auditor noted that the recommendations for considering updates to the legislation and updating contracts surrounding the provision of ground ambulance services have been implemented in its 2022 report, Volume 1. The Ministry of Health considered contract management best practices when it directed the Saskatchewan Health Authority to develop a performance-based contract template for contracted ground ambulance service providers instead of making changes to the Ambulance Act. In Swift Current and surrounding area, the Saskatchewan Health Authority has transitioned contracts within the 5 privately owned ground ambulance operators to the new format. The provincial auditor noted that the recommendations regarding monitoring response times and following its policy to obtain incident reports for ground ambulance services have been implemented in its 2022 report, Volume 1. And since May of 2019, ambulance services in Emergency Medical Services South Zone are required to provide their area manager a monthly statistical report that explains the reasons specific calls did not meet response times. The area manager also receives a monthly response time compliance report used to confirm the monthly statistical reports provided by the services. In regards to the recommendation for reporting to senior management, the board and the public, the SHA has included metrics in the performance-based agreements with contracted ground ambulance service providers, and reporting against performance metrics is expected to be implemented with the new computer-aided dispatch system, otherwise known as CAD. The CAD went live on November 27th, 2023, with the reporting system to be developed within the next 6 months after that. Thank you.
Thank you. Thank you for the remarks and the work on these fronts. I'd open up now for 2 committee members for questions. Ms. Young.
Thank you. Thank you very much. I recognize the majority of these recommendations have been implemented, and obviously ambulance services are an essential and critical component of the provincial healthcare system, and especially when we look at more rural and remote areas of the province in terms of accessing potentially life-saving care. But in looking at a number of these recommendations, obviously, there's a lot in the news and in the public awareness right now around concerns for wait times for ambulances, even within major urban centers. So with that preamble, looking at the recommendations, even those that have been implemented, recognizing they're seeking to address reporting standards from service providers to the Ministry of Health, they are around. A number of them focus on instances such as like when ground ambulance response times do not meet targets. And given certainly what's out there in the public imagination in the news right now, I'm wondering if you could speak on some trends that you're seeing with some of these key deliverables, such as response times, such as incident reports, specific to the Southwest. But I don't know, perhaps I'm assuming it's the same across the province. So if you're able to speak provincially as well.
Thank you. My name is Brian Witt. I'm the Vice President, Provincial Clinical and Support Services. So your question around the provincial trends, I would say provincially we're continually monitoring EMS services across the province. And one of the big things that we see and identify is a variation in those response times in communities across the province. And so working with our paramedic service providers and the SHA, we meet very regularly in analyzing the data that we have in terms of those response times. And through that, through those meetings, and we work with those partners in identifying what potential future investments we should be making, and working with the ministry in future budget cycles, working in terms of deploying those investments to try to level load and ensure that we're reducing that variation in the community response times.
Thank you. Thank you for that response. Hearing that you're continually monitoring and seeing that performance-based contracts were implemented, and I believe it was fall 2022. If my notes are accurate, the response time of 30 minutes is the current target for ambulance services, and now having performance-based contracts, is that target, is that standard of 30 minutes response time being met? And I suppose what percentage of the time is it met? And then by way of follow-up, if it is not being met with performance-based contracts, what are the outcomes for service providers?
right. Okay. Thank you for the question there. So with the performance-based contracts, the target still remains at that 30 minutes. Within the contracts, we work with the providers, and when we identify, and again, we meet with them quite regularly, weekly and monthly, we have a number of different opportunities to meet with the service providers. When we identify that they aren't meeting those 30-minute targets, we actually will work with them on trying to understand what are the reasons behind that. Were they on another call? Was there a breakdown with equipment? What are those reasons? And there's quite a few that could be in play. And then, again, we work with each of those contractors to identify what are those barriers when they didn't, and what are the opportunities for us to work with them on ensuring that they can maintain and those 30-minute targets. And what are the opportunities that we need in terms of different maybe investments or working with other providers to help support that particular provider.
Thank you very much. Just to restate it, my question was specifically around whether or not the 30-minute target was met, what percentage of the time it was met, and what the number of, how many calls are received in which that target is actually achieved. I see in the information provided by the Office of the Provincial Auditor, it appears to indicate that operators consistently provide that information. I believe it also notes that it's provided monthly. If that information isn't readily available for the committee today, also happy to receive it at a later date. But again, specifically, the 30-minute time, how often that is achieved, how often it is not, and for what number of calls.
We don't have that information today, but we will be able to follow up with the committee and get that to you right away.
Thank you very much. I appreciate it.
Thanks for that. And so you're collecting information on this front. You're getting those reports. I guess that's, I appreciate the undertaking. If you could just provide that information in a fulsome way with, as the member has asked those questions, but that information back to us. Is it within a 4-week period is that reasonable for you to supply that back to this committee? Thank you very much.
So I see that performance metrics have been included in the updating contracts with ground ambulance service providers, and that theoretically reporting against those metrics is to be implemented with a new computer-aided dispatch system. Is that system functional right now? Up and running?
Yes, it went live November 27th.
That's great. And what was the cost for the development of that system?
All right, the initial cost was $1.4 million to launch, with ongoing maintenance and licensing fees, initially around $600,000 a year, but over 3 years will go down to around $500,000. And this is hosted and housed by the Sask Public Safety Agency as well, too.
Thank you very much. And now looking at the outstanding recommendation number 6, in the auditor's report, it notes that neither the board, senior management, nor the public received reports on key measures related to the delivery of ground ambulance surveys, ground ambulance services. However, in the status update, it notes that performance metrics are included in the updated contracts with ground ambulance service providers. Is there any intent in implementing the recommendation as written, with reports going to senior management, the board, and the public?
Right. Thank you for the question. So I see this as a bit of an equation in a way. So we have the performance-based contract is in place. Now what we have is the CAD system that's in place that we rolled out in November. Together, that's going to work with the data analytics within the CAD and the performance-based metrics within the contracts to help us generate those reports. And so we've committed that over the by 6 months after the rollout of the CAD system here, that we'll start to be able to generate the reports that we need. And we're going to be looking at other reports that are used across the country for benchmarking to make sure that we're sort of generating reports that make sense. And then we fully intend to create these reports for to share with our board and to work with them and their senior leaders as well too within the SHA. It might take a few iterations of the report to get something that's meaningful. There's a lot of analytics within the CAD system now, our new system. So it's just going to be working through what's of value for us and the public and our board and our senior leadership, and how do we generate that into a report that's meaningful.
Thank you. So you said November 27th, 2023 was when the CAD went live. So based on your last comments, anticipated May of 2024, maybe May, June?
Yeah, exactly.
Is when the
May,
first
June
report.
is when we'll start to be able to generate those reports. And then, again, it might take a few iterations to get to something that is truly valuable for us.
Thank you. And I heard in your comments that there is the intent to report to the board and to senior management. Is there the intent to report to the public?
I think that's going to be something that we'll work with the board on, and I don't know if I'll be able to answer that. We'll have to work with the board on that one.
Thank you. And can you remind me who's the board?
Oh, the SHA board?
The SHA board. Okay. Yeah. So it'll be the board of the Saskatchewan Health Authority that's deciding on whether or not there's publicly available information in regards to ambulance service delivery.
Thanks. I can add some clarity. So we'll work with the board on the reporting and the formatting, what that looks like, and then we'll work with the SHA and the Ministry of Health. We'll take that that reporting format, and we'll try to and we'll work together on how we format in terms of that public reporting as well too. Because there's a number of different ways that we can report to the public. So this will be reported to the public. It's just really refining what that report looks like and ensuring that it's appropriate and meaningful.
Thank you very much. And last question for me, it's also noted in the chapter that management committed to creating an annual provincial emergency medical services report with trends and analysis. I'm not sure, does this report exist today? If not, when is it anticipated? And lastly, is this a report that's intended to be public-facing?
That report, it hasn't been created yet. The intent is to use the GAT system to generate that report. And then really, I think we need to generate it first and see what it tells us and to figure out how we essentially use that report. But again, there is a commitment to do that annually, but we haven't generated yet, so we just don't even know what it even looks like yet. That's going to be our work this year.
Great. Thank you. No further questions, Mr. Chair.
Thanks so much. And just to confirm all the information around the meeting the 30-minute target, that'll be provided back to this committee along with more fulsome information around some of the information that's contained in that report. Is that correct? Thanks very much. Just a comment. We appreciate that so many of these recommendations are actually super substantive, that there's tons of different folks that are working on these recommendations. On the actual status updates, just chatting with some of the members around the table, one thing that can really aid us coming into this committee is just having a bit more substance and detail to the components behind the actions. We could share some of the other examples at some point around what we receive from some of the other entities, because what it allows us to have is more information, and then it allows you to sort of drill down where you might feel that there's certain gaps. So just looking at some of the action statements here, they look good. We know there's substantive work. We know there's a lot of work that's gone into this. But if some of those pieces could just be broken out, it really allows us to sort of see what's already happened and what's being collected, or what's being measured, and then where there might be some gaps for us to focus some of our questions. When the statement's a little bit broader or a bit more vague, it lends itself to a lot more scrutiny or questions, if you will. So just something that I think can aid this committee. And I know when we come in here, because it's not our goal to have folks in here longer than they need to be or anything. We recognize how valuable all of your time is, and we try to simply get to the point of where there's gaps or assess our understanding. So a little more information, those status updates, is something that might be really helpful into the future, recognizing all the good work that's going on. So not any further questions on this chapter? Not seeing any. We will move along now to chapter 20. I think she said she was going to sing her stuff.
Chair. The Saskatchewan Health Authority is responsible for establishing and enforcing policies and procedures so long-term care residents get the right medication at the right dosage when required. Chapter 20 of our 2022 report, Volume 1, reports the results of our third follow-up of management's actions on the 2 remaining recommendations we made in our 2014 audit about the authority's processes to manage medication plans for residents in long-term care facilities located in Kindersley and surrounding area. By January 2022, the authority fully implemented the 2 remaining recommendations. The authority implemented a process to audit whether long-term care facilities adhere to policies requiring informed consent from residents or their designated decision makers for the use of medication as a restraint or for changes in high-risk medications. This process contributed toward the authority improving its documentation of informed consent. We found 86% of client files we tested included documentation of consent when using medication as a chemical restraint, and 73% of the files included documentation of consent for changes in high-risk medications. We found the authority's audit results for 3 facilities we visited improved between April and December 2021, noting a 40% improvement associated for high-risk medications and a 20% improvement for medication used as a chemical restraint. Having informed consent reduces the risk a long-term care resident or their designated decision maker is unaware of a medication's effects and the influence it may have on a resident's quality of life. Implementation of a monitoring process, such as periodic audits, is an effective tool to promote staff compliance with informed consent requirements. I'll now pause for the committee's consideration.
Well, thanks so much for this chapter and the follow-up on this front and the work that's been taken on by the ministry. I'll turn it over to DM Smith for some comments, and then we'll open it up for questions.
Thank you. The provincial auditor had noted the Saskatchewan Health Authority had implemented their recommendation to follow the policy to obtain informed written consent from long-term care residents or their designated decision makers prior to using medications as a restraint. The Health Authority implemented a review process to ensure facilities are complying with policies and obtained informed written consent as required. Surrounding the recommendation to have a policy requiring informed written consent for changes in high-risk medications, the provincial auditor has also noted that this was implemented in its 2022 report, Volume 1. Thank you.
Thank you very much. I'll open it up for questions. Ms. Young?
Thank you very much. Recognizing these recommendations are implemented, I just have two quick questions on, I assume 2 quick questions on this chapter. Looking at the auditor's December 2023 report, which I believe found that 13 of 15 contracted special care homes in Saskatoon had more than 27.5% of residents using antipsychotic drugs without a diagnosis of psychosis. I'm wondering if the SHA has a formal policy on antipsychotic medication for non-diagnosed residents.
So I'm Brenda Schwan, and I'm the Vice President for Integrated Rural Health. So to answer your question, so we do have the provincial special care home guidelines. And part of that, we also have the quarterly long-term care indicators. And there is triggers. So if you have antipsychotics without a diagnosis, there would be triggered on that. And if you're above that target, then you need to submit a corrective action plan.
Thank you. And I see that the auditor found 86% of client files included documentation of consent when a restraint medication was used, and 73% included documentation of consent for changing high-risk medications. Understanding that these numbers are from, I think, 2019. If possible, and appreciate they may not be at your fingertips today, but if it's possible for the committee to get those numbers updated for the last 4 years, I suppose, then, 2019 to date, whenever the most recent numbers would be.
So those numbers that you had quoted were on a random audit. So I don't have, like, over the last 4 years. What I can say, though, is we do medication reviews every quarter within the facility, and part of that medication review is the pharmacy printing us a print of all the medications that they're on. The community pharmacist may or may not attend, along with the nurse and the physician, and they would go through and, note what medications a resident would be on, and they would also look for that consent. So those quarterly reviews are happening. Yeah.
Something you like report out on like a quarterly basis or annual basis. Okay, thank you. I understand.
Yeah.
Mr. Chair, I have no further questions.
Any further questions from committee members on Chapter 20? This is the 2022 report, Volume 1. Not seeing any. I'd welcome a motion to conclude consideration of this chapter. Moved by Mr. Fias. All agreed? That's carried. Ms. Young? You're good? Okay. We'll move right along to the next chapter, 20. Oops. Sorry. So just one moment. We'll take just a couple minutes for a recess here. You bet. Okay, folks, we'll keep moving here, and we're going to turn our attention to Chapter 20 from the 2023 report, Volume 1.
Thank you, Mr. Chair. The Saskatchewan Health Authority is responsible for the planning, organization, delivery, and evaluation of the health services it provides. One of the public health and safety issues Saskatchewan faces is suicide. In Saskatchewan, approximately 195 people die by suicide each year. In northern Saskatchewan, suicide is the leading cause of death for people aged 10 to 49. Chapter 20 of our 2023 report, Volume 1, reports the results of our first follow-up of management's actions on the 8 recommendations we made in our 2019 audit about the authority's processes to treat patients at risk of suicide in northwest Saskatchewan. By November 2022, we found the authority fully implemented 2 recommendations and partially implemented the remaining 6 recommendations. The authority implemented the 2 recommendations on pages 200 and 201, where we recommended the Saskatchewan Health Authority conduct risk-based file audits of patients at risk of suicide in northwest Saskatchewan and periodically inspect the safety of its facilities in northwest Saskatchewan, providing services to patients at risk of suicide. We found the authority conducts risk-based file audits to determine whether staff appropriately completed suicide risk assessments and safety plans for the patients, and also periodically inspects the safety of its facilities in northwest Saskatchewan, providing services to patients at risk of suicide. We found the authority conducts risk-based file audits to determine whether staff appropriately completed suicide risk assessments and safety plans for the patients, and also periodically inspects the safety of the Battlefords Union Hospital, where it provides services to those patients. Completing risk-based audits of patient files helps the authority identify areas needing improvement. It also helps reduce the risk that staff are not providing adequate care to patients at risk of suicide. Additionally, preparing rooms to be safe for patient use and periodically inspecting facilities providing services to patients at risk of suicide decreases the risk of a patient committing self-harm while in the authority's care. We found the authority partially implemented the recommendation on page 193, where we recommended the Saskatchewan Health Authority work with others, for example, the Ministry of Health, to analyze key data about rates and prevalence of suicide attempts to rationalize services made available to patients at risk of suicide. Good practice suggests focusing on certain key measures like suicide rates, hospitalization rates for self-injury, and emergency department rates for self-inflicted injury to assess the services provided to patients at risk of suicide. We found that while the authority can request suicide data from the Saskatchewan Coroner's Service, it only analyzed data for communities in the far northwest area of the province. It did not do so for other communities in northwest Saskatchewan. Additionally, the authority indicated it reviews data collected from the Canadian Institute for Health Information on reasons for self-harm hospitalizations, but could not provide evidence of how it used this information to support further analysis or decision-making. Finally, while the authority is able to produce a listing of individuals admitted to emergency departments with a diagnosis of suicidal thoughts, self-harm, or attempted suicide, we found it does not produce this listing for its own analysis on a periodic basis. Our review of such a listing covering an 8-month period found the authority admitted at least 120 individuals to emergency departments in Saskatchewan's northwest with a diagnosis of suicidal thoughts, self-harm, or attempted suicide. Reviewing trends and performing analysis of key data can inform the planning and implementation of treatment programs. It can also help the authority determine whether it gives individuals at risk of suicide in northwest Saskatchewan sufficient access to services and whether the programs make a difference. We found the authority partially implemented the recommendation on page 196, where we recommended the Saskatchewan Health Authority give suitable training to staff located in northwest Saskatchewan caring for patients at risk of suicide. In June 2021, the authority implemented a work standard outlining the minimum mandatory orientation and training for staff caring for patients at risk of suicide. For example, the authority requires staff working with mental health and addictions patients to complete annual training on identifying suicide risks and completing assessment forms and safety plans, augmented with on-the-job training. However, we found the authority does not have a system or process to track training completed by staff. Not centrally tracking staff training increases the risk of staff who work with patients at risk of suicide missing key training courses. Not providing consistent training to staff increases the risk that staff may not follow the practices the authority expects and may provide patients with inconsistent care. We found the authority partially implemented the recommendation on page 197, where we recommended the Saskatchewan Health Authority follow its established protocols to provide psychiatric consultations to patients accessing emergency departments in Northwest Saskatchewan who are at risk of suicide. The authority requires staff to screen patients admitted to emergency departments for risk of suicide using a standard suicide screening assessment. If staff determine the patient is at high risk of suicide, the authority expects staff to consult with a psychiatrist or senior clinician prior to patient discharge. We tested 30 files of patients admitted to emergency departments for suicidal thoughts, self-harm, or attempted suicide, and found 3 instances where the authority did not screen patients to determine their suicide risk levels. As such, we were unable to determine these patients' need for psychiatric consultations. At the time of our testing, these patients had yet to access mental health and addiction services in Northwest Saskatchewan. Emergency department staff inconsistently following the authority's protocols to screen patients for suicide and consulting with psychiatrists prior to patient discharge where necessary increases the risk of those patients not receiving needed support and treatment. We found the authority partially implemented the recommendation on page 197, where we recommended the Saskatchewan Health Authority address barriers to using video conferencing to provide psychiatric services to communities in Northwest Saskatchewan. We found the authority took steps to address patient barriers in using video conferencing to provide psychiatric services in Northwest Saskatchewan. It implemented a new video conferencing system in 2020 to provide more flexibility for patients and clinicians so they can access their appointments from anywhere through an application installed on a computer or mobile device. However, we found patients continue to poorly utilize video conferencing to access psychiatric services. The no-show rate for video conferencing appointments for Northwest Saskatchewan was 36% between January and November 2022. While this is a slight improvement from the no-show rate of at least 50% in 2019, we found the authority does not track or assess why patients are not showing up for their video conferencing appointments. Not determining reasons for the poor use of video conferencing or psychiatric services in Northwest Saskatchewan reduces the authority's opportunities to identify and address barriers. We found the authority partially implemented the recommendation on page 198, where we recommended the Saskatchewan Health Authority analyze reasons patients at risk of suicide miss appointments for mental health outpatient services to help address barriers. In 2019, the authority implemented a work standard providing clear guidance to staff for contacting patients who miss their scheduled appointments. The authority requires staff to attempt contacting the patient within 1 hour of missing their appointment, and again the next day if the first attempt was unsuccessful. Staff must also complete a form documenting the dates and times staff attempted to contact the patient, along with the patient's reason for not attending the appointment. We tested 16 scheduled appointments and found the authority did not attempt to contact 4 patients and complete the required form to document reasons why patients missed their appointments. In addition, while the authority began compiling data for the reasons why patients missed their scheduled appointments in 2022, we found they had yet to complete an assessment of the data to identify barriers for why patients do not attend scheduled appointments. Insufficiently analyzing reasons for missed appointments for outpatient services in Northwest Saskatchewan reduces the authority's opportunities to identify and help patients overcome barriers to attending appointments. Finally, we found the authority partially implemented the recommendation on page 199, where we recommended the Saskatchewan Health Authority follow up with patients who attempted suicide discharged from emergency departments in Northwest Saskatchewan to encourage treatment where needed. Upon discharge, emergency departments refer patients who attempted suicide to outpatient services, including addictions counseling or psychiatric care, or to inpatient services. The authority expects mental health and addiction staff to follow up with patients needing outpatient services the next business day and determine further referrals or follow-up appointments. We tested 30 patient files and found the authority referred all patients to outpatient services, but did not follow up with 5 patients timely or not at all following their discharge. Following up with patients after discharge decreases the risk of patients not receiving the care they need. Proactive follow-up promotes continuity of care and continues the assessment and management of suicide risk. I'll now pause for the committee's consideration.
All right, thank you very much for the follow-up on this chapter and the important work in this chapter. I'll turn it over to Deputy Minister Smith for remarks, and we'll open up for questions.
Thank you. Regarding the recommendation for the Health Authority to collaborate with others and analyze key data for suicide rates and prevalence, the Health Authority has done so by gathering and analyzing key data from broader sources across northern Saskatchewan, or northwest Saskatchewan, pardon me, including the Health Authority's emergency departments, mental health services, the Ministry of Health, and the Saskatchewan Coroner's Office. In response to the findings of the data we analyzed, Mental Health and Addiction Services in Northwest Saskatchewan had invigorated partnerships with families, the school system, and other caregivers to address the increased utilization of emergency room services by children and youth across the greater Northwest. To implement the recommendation to provide suitable training to staff in the Northwest, the Authority has provided up-to-date suicide risk assessment intervention training for all new and existing mental health and addiction staff in the Northwest who were previously not trained. A manual tracking system has been developed within the Mental Health and Addictions Northwest, monitored by program managers for all staff under their supervision. Mental Health and Addiction Services continues to work in partnership with Digital Health Analytics to develop an automated system of tracking required areas of training. Ongoing work continues within the Ministry of Health and other partners to develop a full standardized menu of suicide risk assessment, intervention training options that will be tailored to meet the needs of all staff, including those working in other areas of care, such as primary health care, emergency rooms, and community partners and agencies. Surrounding the recommendation for the Health Authority to follow established protocols to provide psychiatric consultations, 2 work standards have been jointly developed by the Mental Health and Addiction Services, working with the leadership of the emergency departments and primary health care in the Greater Northwest. The work standards, which have been implemented, stipulate how all patients at risk of suicide are to be screened and the process to access psychiatric consults in emergency departments during normal hours of operation, as well as in the after hours. Additionally, the process for referring from emergency departments to psychiatry for consultation for patients at high risk of suicide has been enhanced. The intake system in the Greater Northwest serves to receive referrals from emergency departments and connects patients at risk of suicide to psychiatry for consultations as need be. The 2 work standards mentioned above also provided for emergency room physicians and clinicians to access direct and immediate consultations to the on-call psychiatrist or to the SHA system flow for 24-hour on-call psychiatric consultation. To address the recommendations surrounding barriers to video conferencing to provide psychiatric services, telehealth, and video conferencing as a service package was reviewed by Mental Health and Addiction Services Management, telehealth video conferencing facilitators, psychiatrists, and office administrative staff. This collaboration resulted in a work standard, orientation form, and a no-show form being jointly developed to stipulate service flow to patients. Missed appointments for video conferencing are now included in the monitoring of reasons for missed appointments. This information will serve to rationalize access and delivery processes on an ongoing basis. At the time of the provincial auditor's previous visit, data surrounding missed appointments was just beginning to be gathered for analysis. Clinicians have been reminded of the importance of following the developed work standard. The process for no-show data collection and analysis has been created and implemented. Data has since been gathered with consideration given to the geographic areas of the remote far north versus the large urban areas. Barriers related to remoteness, demographics, personal resource differentials, and other social factors are being identified and addressed. Standardized processes to gather and analyze data so as to establish reasons clients miss appointments have been created and deployed in the Greater Northwest. To address the recommendations surrounding follow-up with discharged patients to encourage treatment, 2 work standards have been developed. All service centres in Northwest Saskatchewan have implemented the process of follow-up with patients at risk of suicide after they are discharged from the emergency department. There is currently a standard process for Northwest Saskatchewan for following up with patients at risk of suicide. The provincial auditor noted in its 2023 report volume 1 that the recommendation to conduct risk-based file audits of patients has been implemented. The SHA has implemented monthly suicide file auditing as a standard clinical procedure in the Greater Northwest. Additionally, mental health and addiction service managers do follow up on audit outcomes that do not meet full compliance and educate clinicians on how to achieve set standards. The provincial auditor noted in its 2023 report volume 1 that the recommendation for periodically inspecting the safety of its facilities providing services to patients at risk of suicide has been implemented. Primary health care executive directors in Northwest Saskatchewan are committed to ensuring annual inspections are completed and results received in a timely manner beginning in March of 2020. This process is occurring as committed. Ongoing consultations, on-site meetings, and site visits in facilities will occur as often as reasonably possible. And managers and staff of inpatient units, particularly inpatient mental health units where patients with higher risks of suicide are admitted, are regularly monitoring their units for safety risks. Thank you.
Thanks so much for the remarks here and the work on these fronts. Incredibly important work. I'll look to committee members now who have questions. Ms. Young.
Thank you. Thank you very much, Mr. Chair. Hoping to go through these relatively sequentially and appreciating that some of this work is at the outset. Deputy Minister, you spoke about key data and the key data being gathered in terms of recommendation number 1 and the analysis that's going on, and how that's been how that's invigorating partnerships, I believe were your words. I'm wondering if you can provide the committee more information on and more specifics on what that actually means and how the data that's being collected is being used to inform and impact any policy decisions and delivery of services available in the Northwest.
Good afternoon. I'm Derek Miller. I'm the Chief Operating Officer with the SHA and happy to be here this afternoon. I'll be answering a few of the questions for this particular chapter. First of all, I'd like to say that this is an area of focus for the SHA, a priority, and we have been working hard to implement the auditor's recommendations and make improvements in this area. First of all, in terms of the data you asked about, what kinds of things are we looking at? We have a quantitative approach where we're looking at the historical data around suicide, people identified as for suicide risk, as well as data that we gather through the coroner's office and the Ministry of Health to help form a picture and an understanding. We also gather qualitative data like through our clinical teams in terms of what they're hearing and seeing as they do their work, and our leaders that are leading our departments in the Northwest. And we've used that to make a number of improvements in how we're working. And part of it is, as we mentioned, on the partnerships and how we're partnering, for example, with schools on improving access to mental health services. We also have the Roots of Hope project, and it's being run out of Buffalo Narrows, and it's really a community-based approach to suicide prevention. So really looking on the front side to try to promote prevention of suicide. We have made a number of decisions around resource allocation within the SHA, both new resources as well as redeploying existing mental health staff into certain areas where we can better address mental health needs. For example, we've added mental health assessors and counselors in La Loche, both in the emergency department as well as in primary health care. We have a coordinator that's leading the Roots of Hope work in Buffalo Narrows. As well, we've introduced primary health care counselors in Isle Cross. We have a regional community nurse that's focused on child and youth mental health services. As well, within the emergency departments in Lloydminster and Battleford's Union Hospital, we have reassigned counselors to work, as well as psychiatric nurses to work within the emergency departments to assist with the assessment processes and support the emergency room physician in clinical decision making, as well as the referrals to psychiatry. And then lastly, we have identified a resource that has been focused exclusively on the recommendations that came out of the auditor's report to help us progress them, as we believe this is a critical importance for us.
Thank you very much. In the introductory comments, I believe it was noted that at the time of writing, the SHA was using data. Forgive me, please correct me if I'm misstating, exclusively from the more far northwest of the Northwest, as opposed to all of northwestern Saskatchewan. I'm wondering if the data collection has been expanded
So in reference to your question about expanding the use of data from the far northwest to include all of the northwest, we have done that, and that is it's reflected in some of the decisions that have been made in terms of resource allocation and deploying additional staff like psychiatric nurses to the emergency departments in Battleford Junior Hospital and counselors in Lloydminster Hospital. So yes.
Thank you. Currently, how many psychiatric consultations have emergency departments in the Northwest conducted? I suppose what I'm asking is, are psychiatric consultations offered in the emergency department for patients at risk of suicide 100% of the time? And if not, if you have any measures of what that would be?
In response to your question, we do have access to psychiatry consult 100% of the time, 24/7 through an on-call service. So that is in place, and we have a work standard that is described by in the auditor's report that directs staff in terms of the steps they need to take for suicide to perform a suicide assessment and what follow-up would look like in terms of accessing that consultant service through psychiatry.
Thank you. So I see on page 193 of the auditor's report in figure 1, there are target timeframes for outpatient psychiatry services, and then below the auditor notes that the actual response, then the auditor notes the actual response times for September 2022. Are those response targets being met now? And I suppose looking back, were they met in 2023? And what percentage of patients are being assessed within those targets for each category?
In response to your question, we have that information. We don't have it available here today, but we can follow up to provide it to the committee.
Thank you very much. I appreciate that.
Just as we have with all the other undertakings of information, just to confirm that can come through the clerk to the committee. And is a month's time, 4 weeks, reasonable to receive that information?
Yes.
Right on.
In her December 2023 report, the provincial auditor discussed child and youth wait times in the Northeast Integrated Service Area. I'm wondering if you're able to speak to the wait times children and youth experience in the Northwest. At this point in time, how many children and youth clients are waiting for psychology services, and how many adults are waiting as well? Forgive me, I said psychology services, and now I'm second guessing whether I should be saying psychology or psychiatry. But I hope you understand the intent of my question.
Could you actually repeat your question?
Sure.
That would be
Sure.
helpful. Thank you.
So in December 2023, the provincial auditor reported on child and youth wait times in the Northeast Integrated Service Area, and I'm wondering if you're able to speak to the wait times children and youth experience in the Northwest. And I'm looking for any point in time numbers that are available for how many kids, how many children and youth are waiting for services.
Thank you for your question. Similar to the last response, we don't have that information at our fingertips today, but we can follow up with a subsequent submission to capture, and it would be a point in time of how many are waiting in the Northwest for psychiatry.
Thank you. Thank you very much for that undertaking. I note that the auditor reported that staff vacancies are often the cause for delays in accessing services. Can you speak to whether the Northwest is still experiencing staffing challenges in mental health-related positions? Can you provide data on existing staff vacancies for various mental health-related positions in the Northwest? I'm not an expert. I'm not sure what kind of list would be comprehensive, but, you know, psychiatry, registered psychiatric nurses, counselors, et cetera.
I'm on a roll here. We're going to have to follow up on that one as well. We don't have it at our fingertips, but some of the types of occupations that we would be reporting on are things like social workers, registered psychiatric nurses, addictions counselors, and so on. And so what we would do is within the 4 weeks we would pull a report that would show what the vacancies are for those occupations.
Thank you. Thank you very much. Maybe a bit of a higher level question about the video conferencing section of the auditor's report. So I see that the SHA did implement the video conferencing to provide psychiatric services to communities in the Northwest. What I'm unclear on is, would all communities have suitable access on the community side to be able to engage with video conferencing as a service?
In terms of your question about video conferencing, I can confirm that our SHA facilities in the Northwest have telehealth capability to support video conferencing with providers. We also know some First Nations communities also have their own telehealth capability that would connect into a provider. And then as well, and the auditor's report mentioned the new systems that was set out, that was recently rolled out, SAS Virtual Visit, which is another way, and it's through, you can be accessed on your mobile home, or not mobile home, your mobile device, in order to access a provider out of your home or wherever you might be.
Thank you. Perhaps asking the question the opposite way, are there any communities in the north, in the Northwest, pardon me, that would not, hearing what you've said about mobile devices, so I recognize that depends on people having access to, a cell phone with video conferencing capabilities, which I recognize you can't track or identify. But is the SHA aware of any communities that wouldn't have access to this service in the Northwest?
We're not able to confirm communities that wouldn't have that access, but I will say that the SAS Virtual Visit is a platform that brings that type of access to different communities that might not have a facility.
Thank you. And is there information available within the SHA in terms of like where folks are accessing these video conferencing services from? Do you have information in terms of how many people have accessed this service specifically in the Northwest? As always, if you don't have that today, that's A-okay.
So in response to your question about the number of people accessing through telehealth or video conferencing, that isn't something that we would have easy access to. And so we can take that one away and check with our teams to see how we could go about gathering that information.
Sure, thank you. And just to maybe expand my interest in asking this question is obviously this is identified as a response to some of the recommendations, and it's been evaluated by the provincial auditors. So I'm interested in how many people in the Northwest are accessing this, and then of course how the SHA plans on measuring the success of this service as it pertains to obviously increasing mental health supports for people in the Northwest and reducing suicides. Maybe taking a step back to a higher level, in the auditor's report, it notes the 3-year average rate of suicide is 17.9 per 100,000 people from 2018 to 2020. Do you have available the 3-year average rate of suicide from 2020 to 23? Were you referring to when you were, or if you have that, just to help us see where the source? Down,
Okay.
I apologize.
192.
Thank
Okay.
you.
Thank you.
It's coming from Stats Canada, so it's probably, that was why it's so dated, but unless you have coroner's data, that would be more current, yeah.
Thank you.
Just looking at the reference point in the auditor's report is references Statistics Canada as the source, and we acknowledge that, and we are able to provide a rate for suicide per 100,000 based on the Saskatchewan coroner report. So not exactly the same data, but in terms of providing a bit of a update, we can say that for the 5-year period, 2018 to 2022, the average annual rate of suicides per 100,000 population in Saskatchewan was 15.9. And so that is a decrease from the 17.9, although the time periods, there's some slight overlap in there, but it does go up to 2022.
Thank you. And noting that's the average rate, do you have that year by year?
We don't have the breakdown by year accessible now, but we can provide that as a follow-up.
Thank you very much. And one last question in this regard. Is the SHA able to look at that information or that comes from the coroner's office in relation to death by suicide statistics and identify how many of those people were from the Northwest? Measure that's available to the SHA in order to tell how many people specifically in the Northwest are dying by suicide?
Thanks. I think that is one that we would have to follow up with the coroner's office to see what, how they're able to break down the data.
Thank you. Thank you very much. Sorry.
Very much on that. Good question. Thanks for the undertaking to follow up with the coroner on that front, and you'll be able to then supply that information to this committee as well. Is that correct? Sort of in the same way that other information will be?
Yeah. Yes, Mr. Chair. We've got some takeaways that we'll have to take a look at, and we would work to see what's possible, what's available, to be able to get back to the committee as soon as we're able to.
Thanks so much.
Thank you. Looking at recommendation 6 specifically, in the status update, it indicates that the SHA has expanded the implementation of a process for following up with clients recently discharged to all sites in northwestern Saskatchewan. Can you be more specific in answering what type of care and follow-up is provided to clients recently discharged from emergency departments who were either at high risk or who attempted suicide?
just in response to your question, when someone is discharged at high risk of suicide, there's a follow-up process. We have a work standard in place, and that our mental health team does an intake to assess the needs and what the care requirements might be going forward. That could be an outpatient type of service with psychiatry or counselor or another mental health provider. It could be accessing addictions programming, whatever they assess on the intake. And again, we develop the work standards in order to help drive consistency in this across our different sites to provide that service to patients.
Thank you. And how do you measure success specific to that recommendation and the work that's being done for people leaving medical care who've attempted suicide?
Regarding a measure of success for patients getting follow-up following an attempted or being identified as high risk for suicide, we would refer back to the provincial auditor's report when they did the review of patient files to identify the number that had successfully achieved and been followed up on, and those that weren't. And so in this case, it's important that, as outlined in our work standard, that the intake process is completed, so the mental health intake worker has been able to contact the patient, and that subsequent to that, that the patient has been able to successfully access the services that they require.
Thank you. And looking at the information available for last year from the coroner's office, many of those who died by suicide in Saskatchewan are Indigenous people. And I'm wondering, I'm not seeing it specifically spoken to in any of the actions indicated here, if you can speak to some of the work being done to address the high rates of suicide amongst Indigenous people, specifically in the Northwest.
just in response to your question about the rates of suicide amongst Indigenous people, which obviously is very serious, and a lot of our efforts have been focused on promoting suicide prevention in communities that access services or provide services to First Nations communities. I mentioned earlier the Roots of Hope program that is focused on suicide prevention and is being run out of Buffalo Narrows, and it's in collaboration with the community and surrounding area. We have, there is a tripartite agreement between FSIN, the Ministry of Health, and Indigenous Services Canada that focuses on suicide prevention in Indigenous populations. One of the examples that that group has been running over the last 2 years is a youth-based land-based camp, which is partly related to suicide prevention. Also, Sturgeon Lake was announced as a new integrated youth services center recently, and they have a focus as well on youth mental health. And then earlier I spoke to a number of positions, mental health workers that have been added in northern communities that are serving significant Indigenous populations, where we've added counselors and nursing staff and others to support mental health and suicide prevention.
Thank you. No further questions, Mr. Chair.
Any further questions from committee members with respect to this chapter here? I know lots of what we're working through here is heavy stuff as well, and some hard realities that folks know throughout this province. So I want to thank those that are involved in the work, and thinking of all those that are working through challenges on these fronts as well. This is not a new, these aren't new recommendations for us here today. We will have follow-up. Thanks for the many undertakings of information to provide back to this committee as well. So at this point in time, not seeing any other folks that want to enter in at this time, I'd welcome a motion to conclude consideration of this chapter. Moved by Mr. Nerline, Deputy Chair, all agreed. That's carried. Recess for 15 seconds while I consult with our clerk here, the boss. Okay, folks, we'll continue and we'll move along, and we'll turn our attention to Chapter 19, and I'll flip it over to the auditor and her office.
Thank you. The Saskatchewan Health Authority is responsible for the provision of MRI services. Efficient use of MRI services can support timely diagnosis and monitoring of injuries and disease. Chapter 19 of our 2022 report, Volume 1, reports the results of our second follow-up of management's actions on the 4 outstanding recommendations we made in our 2017 audit about the authority's processes for efficient use of MRIs in Regina. By February 2022, the authority implemented 1 recommendation and continues to make progress on the 3 remaining recommendations. The authority implemented the recommendation on page 203 regarding regularly analyzing MRI data to determine causes of significant waits of patients for MRI services. We found the authority regularly reviews and analyzes weekly and monthly MRI data to determine causes of significant waits of patients for MRI services, such as staff shortages. The authority also regularly monitors the timeliness of MRI services that contracted private MRI operators provide. We found the authority partially implemented both recommendations on page 204, where we recommended the Saskatchewan Health Authority formally and systematically assess the quality of MRI services that radiologists provide, and that the authority's board receive periodic reports on the timeliness and quality of MRI services, including actions taken to address identified deficiencies. In 2019, the authority began working with eHealth to develop an IT system to help assess the quality of radiologists' interpretations of MRI scans. It plans to use the system to support formal peer reviews of the scans performed. At February 2022, the authority planned to implement the IT system in 2022-23. Once the authority develops a process to assess the quality of MRI services provided, senior management expects to determine the nature and timing of reporting required about MRI service quality. Without formally and systematically assessing the quality of MRI services that radiologists provide, the authority does not know whether they are providing reliable MRI services. Accurate interpretation of MRI scans can be crucial to proper diagnosis and treatment plans for patients. We found the authority partially implemented the final recommendation on page 205, where we recommended the Saskatchewan Health Authority regularly monitor the quality and timeliness of MRI services that contracted private MRI operators provide. The authority had contracts with 2 private MRI operators, with the private MRI operator in Regina contracted for 5,500 MRI scans per year. The authority uses detailed reports to help staff analyze its data about timeliness of MRI services provided by contracted private MRI operators. For example, each week, staff review the list of MRIs sent to private operators and follow up with the operators if they did not schedule MRI requests in a timely manner to understand the reasons why. In addition, the authority completes daily checks in the radiology information system to determine whether radiologists, including private operator radiologists, complete timely reports for the ordering physicians. However, as I described earlier in my presentation, the authority did not yet monitor the quality of MRI services radiologists provide, including those provided by private operators. It is expected to begin doing so in 2022-23. Not monitoring the quality of MRI services provided by the authority and private operator radiologists can affect whether a patient receives an appropriate diagnosis or treatment plan. I'll now pause for the committee's consideration.
Thanks so much for what's a really important chapter or two and a focus. And just to flag, this goes back, this one here till, I guess, 2017. And we've considered this at this table. And anyways, we'll turn it over for brief remarks from the Deputy Minister, and then we'll flip it open for questions.
Thank you very much. The provincial auditor noted that the recommendation to regularly analyze MRI data has been implemented in their 2022 report, Volume 1. The SHA has implemented a process for regularly analyzing MRI data to determine the causes of significant waits of patients for MRI services and support evidence-based decision-making. MRI wait time analysis is reviewed at every medical imaging provincial executive team quarterly meeting. This team includes operational leaders, radiologists, patient and family advisors, and others who support the diagnostic imaging program in Saskatchewan. Surrounding the recommendation to assess the quality of MRI services provided, the Health Authority is working with radiologists to develop a peer learning and review program to help assess the quality of radiologists' interpretations of MRI scans. This will be enhanced by technology updates to the provincial information system. The SHA is making significant progress in implementing this program and expects implementation to be complete by June 30th of 2024. In regards to the recommendation for the board to receive reports on MRI services, the Vice President of Provincial Clinical and Support Services receives monthly updates on the current state of MRI wait times. Additionally, operational leaders are provided weekly reports to supplement the monthly reporting. As described previously, the SHA is developing a peer learning and review program to help assess the quality of radiologist interpretations of MRI scans. Reporting from this program will be provided to senior management and the board. And finally, to implement the recommendation for regular monitoring of the quality and timeliness of MRI operators' services, weekly and monthly reports on timelines are provided to operational and executive leaders who have oversight of medical imaging services. Through ongoing enhancements, the SHA continues to adjust these reports to meet the needs of the team. Assessment of the quality of the MRI services requires the review of the images and reporting by a separate reviewer. An overall medical imaging services peer learning program, which includes MRI services, is in development. Once the peer review program is fully developed and implemented, appropriate reporting will be developed. Thank you.
You bet. Thanks for that. I'll open it up now to the committee for questions. Ms. Young.
Thank you. Thank you very much. Sounding like there's significant work underway, specifically as it pertains to reporting, which I think I heard is occurring weekly and monthly at different levels to various levels of executives. Is it possible to provide the committee with updated data on the number of patients currently waiting to be scheduled for a Regina MRI by priority level as seen in Figure 1 on page 203, but for, of course, the years 2022 and 2023?
All right, thank you. We can't reproduce that data on that table today for you, but we'll get back. We'll work with our teams and we can see what we can bring back to the committee.
Thank you. Thank you very much for that. Looking at outstanding recommendation number 3, recommending that the Board of the Saskatchewan Health Authority receive periodic reports on the timeliness and quality of MRI services, including actions taken to address identified deficiencies. I'm curious how many people are currently waiting for MRI scans in the province, what the longest wait is, and if you can speak to the causes of any significant wait times.
Jim has the longest travel.
skipping school until I know. Practical experience. 17. I got a text this morning.
Oh, your kid got into town last night? Yeah.
I was gonna drive home, but it was like,
Sure, brought him in here. Running back.
his parents.
Yeah, that's what we would call it.
5'8", 5'9". 175. Yeah, he's a pretty sweet dog. Yeah,
You can't keep up.
he's bigger than you. Yeah. Bigger.
You can.
Yeah, but now I'm at this spot where it's just
Yeah.
changing. Won't last long.
I'm impressed you can keep up at that age.
3 times older than you.
Yeah.
Last time we had Pat here to big conference meeting, it was 4, but it was first. Do you have anything back to that, or is that one or 2?
Nope. They might have even come from one of my daughters.
They kept me a steak. I was late. Yeah, there have been some bad days.
No,
It's
that's
pricey.
too, yeah.
It's pricey for me.
There have been some bad days.
I think so. I wasn't up there, but it was bad weather, so I know someone was good to be here. But I was assuming maybe it was contested. Yeah, there was 3 guests. Yeah, that's right. Tonight, is that 2? Or 3? Two people, they 2 little ones. Last night was Riverside. Yeah, yeah, yeah.
I don't know the gal who wanted her nice. Well, at all, but.
Very young.
Yeah, like younger lawyer, big enough in arts organization. It's the Drag Racing Association.
All right, thank you for the question. There are approximately 11,000 patients waiting for MRIs right now. I don't have the longest waiter in front of me here, but what I have is the 90th percentile is waiting around 271 days, but we do see variation within that. So for example, in Regina, we're seeing patients in the 90th percentile waiting 351 days. In terms of the causes of this, I think there's a number that we consider in Regina and really across the province, but especially in Regina, we see a lot with HR challenges, hard to recruit. MRTs, they're in high demand across the entire country. We also see the demand is increasing, and so this is where a really good example where we see the value of the reporting that we're doing. And so when you look at the data and you start to break it down by different geographic areas, you can really see the demand and the capacity within those areas. And when you break it down, you could see in Saskatoon, we actually hit some of our 90th percentile targets, and because the demand was aligning with the capacity within that city. In Regina, we don't have that same alignment. And so we were able to take that data and then work with the Ministry of Health, and we're going to be adding an in-hospital MRI system to Regina. It's going to start as a portable MRI until we can get the permanent one in place. And so it's just a really great example of how we can align the data that tells the story in terms of what are those key investments that we need to make that will be really the most impactful for the total province.
Thank you very much. I have 2 follow-up questions to that. I was going to ask, you mentioned the staffing challenges, which we've spoken about earlier today, and so I was wondering if you were able to identify kind of geographically what facilities were experiencing staffing challenges, where those were in the province. And I was also curious, you mentioned the portable scanner in terms of an investment. How many MRI scanners does SHA currently operate, and which facilities are those in?
Thank you for the question. I would say in terms of staffing, we would have staffing challenges across every MRI sort of facility that we have. So Saskatoon, Regina, Moose Jaw. Different collective agreements allow us to work with our staffing, but we're also, you recruit, we have some new graduates, and then maybe we have some staff who may go on maternity leave. Or so it's a very fluctuating kind of thing that we're constantly monitoring and having to adjust and recruit. In terms of the number of MRIs, so in Saskatoon at RUH we have 2 MRIs, and we have one at City Hospital and one at St. Paul's. In Regina at RGH we have 2 MRIs, and then we have the future planned MRI that's going to go into Pasquale Hospital. It will start off at RGH, the portable one, while we do the construction at Pasquale Hospital. RGH has the existing pad and infrastructure for it, so that's our quickest way to get it in. We will move that temporary infrastructure to Pasquale Hospital because we want to get that patient flow working and support the cancer agency as well too. So, and then we'll have the permanent magnet there. In terms of community MRIs as well too, we have 2 in Saskatoon and 2 in Regina as well too. And sorry, don't want to forget Moose Jaw. Wigmore Hospital has an MRI system as well too.
And forgive me, are community MRIs the privately operated MRIs?
Yes.
Okay, great, thank you. So looking at the 2 outstanding recommendations and the reporting that is underway, the SHA is tracking the number of patients accessing MRIs, both through public and through private delivery. Are the wait times? I suppose I'm looking at whether the wait times are comparable for private operators as they are for the public system, as well as the concerns that have been identified around quality. If people accessing these services in Saskatchewan can expect a similar wait time, but also similar quality through both public delivery and private delivery, and then if that information is tracked, which it appears to be, if you have that for the last few years for both the public and the private operators.
There we go. Mic wasn't turning on. I could yell. I'm pretty loud sometimes. In terms of the wait times, there's actually no separate wait time for public versus the private. How we do it is we basically incorporate it into our current wait time. So we treat a community magnet just for those patients just as we would our own magnets. And so the patients they flow seamlessly through our system. So, if you're deemed to require this certain type of imaging, and we earmark you for a community magnet versus an in-hospital one, you just flow there, and all that tracking is all within the same scope. In terms of the quality, I think there's two elements. One is in terms of quality of radiologists. All private MRI radiologists are accredited by the College of Physicians and Surgeons within Saskatchewan. But I think more importantly is what the auditor is working with us on is the new peer learning and peer review process that we want to implement. That's actually we're very excited about this, and we're very close to actually turning that on and implementing it. And the value of this is it's really going to allow us to through a learning and through a peer review process, assess the quality of the reads from not just in Regina and not just the private radiologists, but all radiologists across the Saskatchewan that are reading for the SHA. And it's done in a way that that is going to be able to learn and grow and help the radiologists if maybe we find that some reports are lacking, and be able to actually be an opportunity to mentor and learn and actually support and identify where maybe there are some challenges with the reads, but also where we can actually take really good reads and then help teach other radiologists to grow and be better.
Thank you for that clarification. I think it helps me understand a little bit more. Then the rationale for the two different recommendations, number 3 and number 4, one speaking to, at least by my read, kind of traditionally delivered MRI services, and the fourth recommendation speaking to private delivery. The reason those are then broken out, hearing what was just said, like wait times are the same, you just get funneled to where you get funneled. The concern is really about ensuring that there's same quality being delivered at.
Absolutely, yeah. And like, as the SHA's indicated, that really from that quality oversight perspective, it'll be across all radiologists, whether at the private or at. The other thing is there was a component to timeliness here, and now we are satisfied that the timeliness, and there is monitoring that should be taking place from that oversight perspective, again, from the SHA side, when it comes to are the private operators doing timely scans, and we found they are, and now we just want to see that quality rollout being rolled out to all radiologists, whether you're working at a private operator or for the SHA.
Okay, thank you. I appreciate the clarification. Helps me. My last question on this: is there, I don't know what the right words are. Is there a cost differential for a patient accessing a private or a traditionally delivered MRI?
This is on rewrites. You gotta watch it.
I have the tolerance for like suspense or drama or tragedy of like a 5-year-old child. Like I can watch comedies, nothing else. I just too many of those shows were like sadly was happening to kids or just I can't. I did watch a good TV show,
Your question, I believe it says something like cost to the patient, but I don't think that was what you were looking for. No. Yeah. So
patient, yeah.
I made an assumption there.
I
My
assume
answer.
we're not charging patients.
No,
Yeah. Unless something's changed.
That would be an easy answer. In terms of the cost differential, to contract out, there is a process that we do in terms of comparing the values of in-house services, in-hospital services versus contracted out service. We went through this years ago when we went and did the initial contracts with the service providers. It was found that the private provider service was more cost effective than the hospital delivered service there, and that still remains.
True. Okay. And would those figures be, if didn't go back and look to 2016 or whatever that was, those figures would remain the same then?
Yeah, there's inflationary changes year over year, but both inflationary changes impact both systems as well too.
Okay, thank you. And do you have saving me the research, do you have the current numbers with inflationary changes for the past however many years?
I wouldn't have them here today, no. Let's just, well, let me just look here. Thank you for the question. The SHA, it's a SHA negotiated rate with a third party, and we're unable to disclose that rate right now just because it might impact future negotiations with them. And so, yeah, for now, it's kind of a confidential rate.
Fair enough? Yeah. Okay. Good. Okay, yep. Good, thank you, Mr. Chair.
Okay. I think there's a bunch more questions coming over here. Any further questions, folks? Not seeing any with respect to this important chapter. Thanks as well for the information you're going to be providing back and the work that you've committed to ensure implementation on these fronts. That's all really appreciated. I would welcome a motion to conclude consideration of this chapter. Moved by Ms. Lambert. All agreed? That's carried. Respecting the time of the day, which is 5:23, I think, p.m. Oh, that clock is, boy, that's good to know, 5:26 p.m. We won't be proceeding with the rest of the items on the agenda today. Those we will deal with those at a future hearing as a committee. At this time, I just want to say thank you so much to Deputy Minister Smith and the awesome team of officials that have joined us here today, and we know there's a whole bunch of others that are patched into this work and connected to the considerations here today and involved in implementation and providing care across Saskatchewan. We know our health system is complex with many pressures and challenges and lots of care within it, and we know lots of the stuff we're discussing is complex as well with no simple often not simple answers. So thanks to you all that work to provide care and health care and services to the people of the province, all from corner to corner to corner. Deputy Minister Smith, 2 good full days here with you. Any final remarks on behalf of your team before we shut this thing down?
I just want to say thank you to the committee for the time and the questions that were brought forward, because I do think it enables us, along with our partners within eHealth specifically and the SHA, to be able to show a lot of the great work and progress that is happening across the system. And so having some time to do that today and yesterday, we really appreciate the questions. And again, to the team behind me and back at various locations and to the system as a whole, it's really the individuals that work within the healthcare system that are working to implement all these changes. And I think we all really appreciate the efforts that go on every single day in our province. So thank you.
No, that's great. And thank you to the auditor and their team for their dedication, their focus on these fronts, and their diligence in following up as well, and the relationship where the entity, the ministry, the health authority, where they work together with the auditor on these fronts. So, and to our clerk and Hansard and all the committee members, thanks for a good couple days. So with all that being said, I know the member from Melfort is hungry. I would welcome a motion of adjournment moved by Mr. Harrison. All agreed? That's carried. This committee stands adjourned until the call of the chair.